Hello everybody. Welcome to the last BEGO Implant Systems online seminar for professionals of 2020. My name is Marcio Garcia dos Santos. I'm part of BEGO Implant Systems education and clinical research team, and I will be the moderator of today's session. First of all, I hope that you and your family are all in good health. And before introducing our speaker, I would like to thank Mrs. Angelica Jacob, from BEGO Implant Systems Marketing Department for the organization of this session. The topic today will be reaching outstanding clinical results, screw retained rehabilitations with multi-plus abutments, and the speaker will be my friend Dr. Kleanthis Manolakis from Greece. Dr. Manolakis is a dentist, was a visiting doctor at the Department of Fixed and Removable Prosthodontics and Dental Materials, also from the Department of Oral and Maxillofacial Surgery at the University of Zurich, Switzerland. For 25 years, he has his private clinic in Thessaloniki, Greece, and a large experience in clinical implantology, with over 2,000 implants restored both surgically and prosthetically. Extensive experience in 3D implant treatment planning, implant full mouth restorations, and immediate loading protocols. He is a course director and instructor for international and training courses performed at his own clinic and several countries, giving lectures and scientific meetings and academic institutions. He is founding member of the Greek Academy of Aesthetic Dentistry and country chairman for Greece at the European Society of Cosmetic Dentistry. Dear Cleo, thanks for accepting the invitation to conduct this session. As always, at the end of the lecture, we will have a question and answer session, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time and give the words to Dr. Manolakis.
Good morning, dear friends, dear colleagues. Thank you, Marcio, for the kind invitation. We have been cooperating with Marcio for several years and with BEGO for over 11 years, and I started placing the multi-plus abutments. Now it's about 7 or 8 years, so it is a very reliable system. I'm very happy to be part of this online meeting. The virtual online seminars, it was an opportunity that we were not aware of. Just a few, almost actually this year and last year we started doing a little bit of online seminars. I apologize for my haircut, no possibility to fix it, because of the restriction, but I have a nice shave, and I would like to welcome you all to this sharing of our experience in our office with the multi-plus system by BEGO. I hope you can benefit from this presentation. At the end, I would like to receive your questions, and let's get started. So actually, when we are applying clinical protocols, we should answer one basic question, which is screw retained or cement retained restorations. This is a baseline. And in our office, we did some cement retained restorations in the past, but in the recent years, we refrained from using cement retained restorations. We're only focusing on screw retained restorations because of the predictability of this regime. So in my understanding, an implant supported restoration must be predictable over time. Predictability and retrievability are guaranteed and are facilitated only through screw retained restorations. Okay, and the multi-plus system is a vital integral part of this treatment protocol. I would like to share with you several cases, some bigger and some maybe smaller cases, all of them with an extensive follow-up, so that we can really observe how this treatment modality serves over time. The multi-plus abutment is an abutment that is positioned on the implant, and it facilitates a modification of the implant abutment interface, so we don't place our restoration at the implant level, we place our restoration at the abutment level, so we move one floor up. And to my understanding, this is a vital part of the longevity of the restoration. I prefer to move away from the implant abutment interface and control my prosthetic restoration move away from the implant level. We have access to straight abutments, multiplus abutments, and also to angulated multiplus abutments for the correction of angulation. Actually, the system allows us to modify the angulation of the prosthetic restoration, so that irrespectively of the angulation of the abutments, we can always go into a parallel position of our prosthetic restoration. We will go step by step in these features in the following slides. The internal hex serves as an anti-rotational feature. This is where the abutment is positioned and secured into the implant neck, and a gap-free seating on the internal taper ensures a tight seal. As discussed before, a solid treatment planning of every single clinical case is a prerequisite. We should always focus and take our time to define an implant case even more extensive scenario, so that we are prepared beforehand. So we should have a clear treatment planning before we place our implants, and this is vital, irrespective of whether we use multiplus or some other system for securing the restoration. This is a classical example, typical example of a solid treatment planning that was not facilitated properly. So the dental technician on a forum online is explaining his problem. Now the doctor, ourselves, we want the restoration to be screw retained. Any ideas? We should never leave the final judgment to our dental technicians. It is our responsibility to define the treatment plan. So let's start with some cross-arch cases. For example, let's take the indication of the immediate loading variation. So this is a case I would like to share with you. It's an old case that we started back in 2011. It involves the lower jaw. We are planning a fixed cross-arch restoration, and it is an immediate loading case. In this scenario, 4 implants are placed with multiplus abutments and the porcelain fused metal bridge. This would be the final restoration. So let's go step by step. After interview and clinical examination, our patient in the end of 70, she's 77, 78 at that time, and she wishes an implant-supported fixed restoration. She doesn't want the removable restoration for her lower jaw anymore. The anterior segment of the lower jaw, most of the time we have sufficient bone to place some implants, but in the posterior segment, at times we don't have enough bone, like in this case. So we will go for an angulated implant placement. Let's have a look. Treatment planning. We start with a conventional and digital imaging, and our treatment plan involves extraction of remaining lower natural teeth, and then the interforaminal placement of 4 RI implants. And in case we can achieve a primary stability which is sufficient, and the magical number is 35 Newton centimeter plus, then we can proceed with an immediate loading protocol. Now the treatment sequence is the following. We will extract the remaining teeth, then we can modify the osseous crest, carefully flatten the osseous crest, and then insert 4 Semados RI implants in this fashion. So some of them are straight. In the anterior segment, we can place implants in a parallel fashion, and in the posterior segment, we are forced to work with angulated implant placement, because we want to save some anatomical structures that we should keep away from. Okay, so in this way, by placing tilted implants, we can extend a fixed restoration more in the posterior segments. Is it possible to do immediate loading? It depends. actually do not guarantee to our patients that we will provide immediate loading, because we don't know before placing the implants what the torque will be, the value of initial stability of the implants. But in this case, we achieve values of more than 40 Newton centimeter, so we can proceed surgically with placing the multi-units during the surgery. An advantage, and a good advantage, an important advantage of the BEGO line is that these multi-plus titanium abutments are delivered sterilized, so we can in a very, very comfortable and predictable way use them during the surgery. And I like in general to place, if possible, the multi-abutments surgically in order to control the implant abutment interface and in order to be sure that they are positioned properly. Okay, in the posterior transfer post on the left side, you see an angulation correction indicator that can help us visualize the angulation diversion between the surgical and the prosthetic interface. So we proceed with final tightening intraoperatively of the multi-plus, and then we use the specific impression posts. We can proceed actually with the impression intraoperatively. We first place the posts and then we suture the area, and these are the multi-analogs in the abutment in the lab. This is a transitional restoration which has no cantilevers. We shouldn't do cantilevers during the transitional restoration. 2 days later, we can deliver the final restoration. We remove the healing abutments that are specifically designed for the multi-plus, and we insert the transitional fixed restoration. Okay. Now, actually 3 months later, or 6 months later, or 9 months later, or a year later, we can proceed for the final restoration. It depends on the healing mode. It depends on whether the patient is in a vicinity or he is living far away. In this case, our patient is living in Athens, the capital of Greece. She had some family obligations, so she couldn't attend 3 months later. But at 9 months, this is the appointment for the final replacement of the final restoration. This is a cross-arch PFM fixed restoration on these 4 implants, screw retained. This is the intraoral placement. Please observe the fine peri-implant soft tissue maturation. We have an inflammation-free peri-implant mucosa because we can produce a fine prosthetic level restoration that is cleansable. This is our final restoration in situ, and this is one happy patient. It was not an easy treatment, and she's not the easy type of patient. This final restoration, fixed restoration on multi-plus, provides our patients with an excellent masticatory and functional result most of the time. This is a 2.5-year follow-up. We have a minimal crestal remodeling. Actually, we have hardly any bone loss on the implant abutment interface, and the 7-year follow-up after she had a severe car accident. Part of the ceramic in the upper jaw was chipping, one bridge in the upper jaw debonded in the lower jaw. She had just minimal chipping. Other than that, excellent oral hygiene, excellent soft and hard tissue stability. We called on the phone last week. She's now at a 9.5-year follow-up, and she's enjoying her implant restoration in a fine way. So this is a predictable long-term solution for this type of patients. 7-year follow-up. It can be usually it is a picture like this, where the soft tissue, hard and soft tissue configuration is fine because our patients can clean, they can take care of this restoration. Okay, conclusions out of our first case: the multi-plus abutments can provide optimal treatment outcomes in immediate loading clinical realities. This is for sure.